Good night, my name is Giancarlo Lange, and today I'm going to about I'm going to speak about catheterism in subclavian vein. The introduction. Central venous catheterization signs its appearance in 1952 as an intervention technique in patients. Citrus has allowed us to manage disease and emerging states. The resolution represents the increased survival of patients, being an invasive producer and not be without complication. Its multidisciplinary approach has demonstrated value for money and greater efficacy for the frequency, severity, and type of complication is reduced. I mean to know the variables that may influence the presentation of medical complications, those that depend on the operator, the patient, or the circumstance under which the path is channeled could estimate the probability that a patient occurs. A complication so try to mitigate the variables that could determine the success of making venous access. The applications in medicines, the venous catheterization is defined as insertion of a biocompatible catheter into space intravascular, central, or peripheral in order to administer fluids, drugs, nutritions, parenterals, determine physiological constants, perform diagnostic tests, among others. Central venous catheters are proof that are introduced into the great vessels venous thorax, abdomen or cavities, cardiac cavities, right, with finds diagnostics or therapeutics in the right heart for diagnostic purpose or therapeutics. This is a video that show how is the introduction of the catheter.
A linear array transducer with a venous exam type is used to perform an ultrasound-guided insertion of an internal jugular catheter via a transverse approach. The patient is in a supine position with the head slightly turned toward the contralateral side. The operator is positioned at the head of the bed. The transducer is placed transversely just below the apex of the sternocleidomastoid muscle triangle, with the orientation marker directed to the patient's left at a 9 o'clock position. The most superficial structure identified in the ultrasound image is the sternocleidomastoid muscle. Deeper to this, the internal jugular vein will appear as a dark anechoic elliptical shape and is compressible with transducer pressure. The artery will be circular and pulsatile. The thyroid gland lies medial to these structures and has a light gray echo signature. Adjust the transducer so it is centered over the internal jugular vein. Follow the needle entry by slowly sliding the transducer in the direction of needle advancement. The needle will appear as a small, bright, hyperechoic dot. When the needle tip appears, the transducer should be advanced a short distance distally to follow the tip of the needle trajectory and stay in advance of the needle entry. The needle is slowly advanced under direct ultrasound visualization until the tip is seen to indent and then puncture the internal jugular vein. The transducer should be moved slightly proximally and distally to confirm that the needle tip lies in the mid-portion of the jugular vein.
Well, continue. We're going to about the pros and cons in this method. Okay, the pros. The first pros is the visualization of vascular structures. The second, optimal location of the needle. Third, protection against perforation of the wall later of the VGI. And fourth, precise location of the catheter. Decrease in the time of the procedure. Decrease in the number of attempts and low complication rate. The cons is that you need the technology, obviously, Second, love of technical skills using points anatomicals and false sense of security, and increase in the cost of equipment. And next, this is another video on how they do this.
Before proceeding with vascular puncture, it is appropriate to perform an ultrasound exam of the cervical region. On the short or transversal axis, the internal jugular vein is identified as a vessel anterolateral to the common carotid artery, which is compressible and non-pulsatile. By examining in a craniocaudal direction along the same axis, the carotid bifurcation and innominate artery can be observed. The jugular vein and carotid artery can also be examined in the long or longitudinal axis. And along the oblique axis, halfway between the longitudinal and transversal axes.
This is the pain.
After removing the remnants of gel, the skin is prepared with an antiseptic solution. The cannulator prepares the material and surgical field using an aseptic technique. The ultrasound transducer is then covered using a sterile sheath to avoid contaminating the surgical field. Using sterile saline solution as a coupling medium, the internal jugular vein is relocated on the short axis, such that it is located in the middle of the ultrasound image. The Seldinger needle is introduced, out of plane, at the midpoint of the transducer. Aspiration of venous blood confirms the intravascular position of the needle tip. The transducer is then removed and the guide wire introduced through the needle. If resistance is observed during the guide wire advance, as in this case, remove the needle and locate the wire using ultrasound. After verifying that the wire is in an intravascular position in the jugular vein, a new insertion can then be attempted. If resistance is encountered again, locate the wire on the long axis and withdraw it until the J-tip is identified, which is when a new insertion attempt can be made. In this case, this attempt was successful. Once the guide wire is inserted, continue with the Seldinger technique for catheter insertion.
This kind of catheter can be used for uh, insufficiency, renal insufficiency for the dialysis. Okay, we can see, but here's a application in Ecuador. So in Ecuador, they do an studio that compares the techniques with guided by a echo and not the guide. O sea, so it's the regular, the old techniques versus the new techniques, and the conclusions was that the complications are reduced with the use of real-time echo for the placement of central lines. There is a less risk of complications with only one puncture than with more than two punctures, so it's better with the echo. This is another video how they do it. This is the carotids, and this is the jugularis. And it's doing with echo. This confirms that you are in the vein. You remove, and then you put the catheter. This is the guide. Here they go. That was looked like it was for a dialysis. I don't know, but looks like. Well, in the conclusions, central venous catheters are a fundamental tool in the management of critical patients, which is why it should be widely no insertions technique, and its complication that most use vein is the PGI, being this widely study in its anatomical repairs, insertion technique, and complications. So, if you want to do a catheterings, do it with an echo. It's more recommended. Thanks for watching.